tools.
Thank you, Daniel. So yes, my case is far easier than Panos one, so it will be pretty straightforward. So we have a 40-year-old man with hypertension, dyslipidemia, with effort angina, with CCS3, started nitro and ranolazine, but still some symptoms. The echo is normal and the lab is not relevant. So you can see the angio here. So you see from the caudal view that you have some kind of disease in the proximal part of the LAD, and from the cranial view you see that better that you have serial lesions in the LAD from the angio. So I would say, what are your ideas about this patient? What would you do if you need more information to treat the patient, and how would you do that? The right was normal, sorry, I didn't tell you. But.
Yes, I see a case of two tandem lesions in the LAD. The first one is very close to the ostium of the LAD. So here I would probably use imaging, OCT, instead of physiology, in order to plan. And I'm pretty certain that the second lesion is a significant one.
So you already made your decision regarding treatment based on angio, saying, okay, this is a significant lesion, so I will treat it now. I have to proceed with planning the procedure, and that's why I need imaging.
If I had any a colleague who would tell otherwise, I would use a pressure wire.
But a pressure wire you would use?
Yes.
Okay.
I could do both. I could do both. In our cath lab, we can do both, but the second lesion is pretty tight for me. So I would predilate and treat the second lesion and see with imaging the first one, the proximal one.
Okay. Tom?
Shame we didn't have a CT. I think a CT would have been lovely before this, because that would tell you. I think these tandem lesions are tricky. So I would take a pressure wire distal and I would do an FFR. And that to me says, am I going to treat the vessel or not? I wait for the adenosine to disappear, and I tend to do a resting pullback. Me too, yeah. Because I think resting pullback is scientifically more valid than an FFR pullback by definition, and then look for the steps across those two components and try and work out if you think they're both equally important, or whether in fact you think just one of them is got more of a pressure drop. And then I would probably just treat one of them first, reassess, and then inevitably, probably in this case, treat both. Okay. I don't know.
And?
I think I would go with both imaging and pressure wire. That's it.
So, in spirit of the course, imaging and physiology.
In tandem.
Yeah.
Okay.
What did you do?
So what we did was to perform angiography-derived FFR. This is from the PULSE system, so it can be done either with one projection or two projections, according to what you prefer. In the reconstruction, they take into account the side branches, so you can also include the left main, because you will have a reconstruction of the impact of the flow of the circ. So in this case, it was important because, as you said, you had disease in the ostial part of the LAD. So if you use a system that doesn't take into account the left main, in this case, it would have been tricky, because you could underestimate the importance and the diameter of the ostial part of the LAD. And what you see here from the pullback curve is that obviously the value is positive, because you see on the right part that is below 0.7. So as you may anticipate from the angio, this vessel is ischemic, the flow is limited. But what you see from the pullback curve, that is the one with all the colors, is that you have two different gradients at the level of the two lesions. And what you can do, obviously in this case, we wanted to be sure, so because it was part of a study, so we performed also invasive FFR with the PPG. That was something we discussed in the first part of the day. And what you see from the invasive curve is again two different pullbacks. What we do when we perform pullback with FFR is to put a marker at the level of the lesions while we are putting back the wire in order to be sure that this is the place where the lesion was. And what you see here is two distinct gradients at the level of the two lesions. And if you want to know something about the PPG we discussed before, that is a value between 0 and 1. 1 means very focal lesion. The 0 means very diffuse disease. What happens with the PPG is that it's most often in the gray zone, so in the middle, as in this case, it's 0.56. If you have a look at all the work by Carlos Collet, you know that the PPG is considered focal from 0.65 up, so this would be diffuse disease. I would argue that this is diffuse disease, this is tandem lesion. So in some cases you can use PPG to guide your treatment, in other cases you for sure have to look at the pullback curve, because in this case it's not diffuse disease, it's two very focal lesions, so it's not something that you cannot treat with PCI. So that was also the point we were making before, to use physiology at the 100% of what can give to you. So what we can do with these systems is to try to plan our procedure. So what you see down here is the stent that you could place in the mid portion of the LAD, and this is the residual predicted value after the stenting. So you can see that in this case, if you treat just a distal lesion, that's the tighter one from the angiography, you will end up with the suboptimal result, because 0.83 is not great. And again, obviously, if you treat only the proximal lesion, you will end up even worse with 0.79. So the idea in this case is that we knew from the beginning that probably the best way to treat this patient was to put two stents, one in the proximal and one in the mid portion of the vessel. You can also try to put two stents with the planner, so you see that you will have a good residual QFR or μFR, as you may know. You have to take into account that, especially for LAD, the predicted value with those systems is far higher than the one you will see by putting the wire and measuring FFR actually, because you will never end up with 0.95 with FFR, because there are basically, it doesn't exist an LAD with an FFR of 0.95. It's at least 0.90 most of the times. So it's not that you will end up with that value, but it tells you that it's the best you can do for this patient. So it's not that you will have the correct value at the end of it, but you know that from some studies that if you reach 0.90 by QFR after PCI, this is actually associated with a good prognosis for the patient. So what we did was to treat both lesions, and what you see afterwards is that the angiographic result is good in the proximal portion, but you have some kind of under expansion in the mid stent. You see it from the angio, and what you can do, but this is not actually the way I do in my clinical practice. You can also measure it after PCI, but the measurement of QFR, μFR, all the system after PCI inside the stent is not always accurate, because in this case it was I would say huge under expansion. You see it also from the angio, but in some cases QFR is pristine, and if you perform IVUS or OCT, that is, I think, the gold standard for stent evaluation, you will end up doing post-dilation because of under expansion or malapposition. You can also do post-PCI FFR. You see some gradient in the distal stent that is in line with what we see with the angio, but if you don't have the imaging available in all the cases, a good way to understand something more about the stent is to perform an enhanced stent visualization, and even in this case you can see that in the mid portion of the vessel you have some kind of under expansion that needs to be treated, and so actually we end up doing another post-dilation in the distal part of the vessel, and the final result was a little bit better, even if not perfect. So that was how we managed the case. Thank you.
Thank you. May I perhaps direct a question to you, being an expert in the field? How do you comment the FAVOR trial? I mean, that's the elephant in the room.
Yeah.
So now, from now on, we will have to refer to the trial, I think, until there is another one, and try to explain what happened there and how we can move along with these results.
Yeah.
So in the FAVOR trial, the wire-based
Exactly.
FFR was just better
Yeah.
than the angio-derived in terms of clinical outcomes.
Exactly. So the FAVOR 3 trial basically was in the stable setting mostly. So what we can understand from the FAVOR 3 Europe and Japan study is that FFR is very good right now. So you have to stick, especially in the stable setting, with the invasive physiology. And the reasons are basically the one we saw in the cases, because if you have a negative physiology, we will go with the CFR, IMR, acetylcholine, and then also the ability to estimate FFR of QFR in stable setting is probably intermediate right now, so it's not the best. The reasons for these results, I would say that there are many reasons, but the most important one is that the one we were discussing before. All these systems are not automatic, so basically there is still much interaction of the operator with the system. So for example, what happened in the FAVOR 3 trial was that there were many circumflex positive in the QFR arm, whereas there were 0 lesions with positive assessment with FFR, and who is doing physiology on a daily basis knows that circumflex is 95% of the cases negative. But if you see a very tight lesion, what you will end up doing is to draw the contour in order to have a positive assessment, or at least move the post like a little bit in order to be able to score. So I would say that the best solution for those systems will be to become completely automatic. So no operator interaction, and you will end up with a value that can be an estimation of the FFR, not 100% right. Probably, in my opinion, the best niche, the best solution for this kind of setting is in the acute setting, in the non-culprit evaluation of in STEMI, for example, because there it's unlikely to perform FFR during primary PCI at 3 a.m. in the morning after, an anterior MI. So if the patient is stable, if you have good hemodynamic conditions and you can perform your a good angiography on the non-culprit, that would make sense instead of performing evaluation with the wire. But right now, in the stable setting, you have to go with the wire.
Okay, and there is another, I think, very important issue which you demonstrated nicely here, and that is longitudinal vessel analysis. So you need to understand the interplay of the lesions, and there is, I think, a hugely open question whether you need to do that with non-hyperemic indices, so with rest flow, or whether you need to induce hyperemia. I mean, we know that without hyperemia, we will have a longitudinal vessel analysis on some systems, severe automatic, which has been tested for some time, and I'm eager to see, of course, the studies now with the PPG. However, I think the dilemma will remain because, at least in my experience, so what happens is that you will have 20%, and this is documented in the literature, 20% difference between resting indices and FFR at the start of the procedure. I mean, if you do it at the beginning. Now, if you want to do longitudinal vessel analysis, the pullback in a patient where there is a discrepancy of FFR and RFR, for example, that's a big question for me. So what I do at present with the pressure wire, which doesn't have an automatic, let's say, a pullback analysis, I do FFR and RFR at the beginning. If they point into the same direction, I'm pretty confident with the RFR pullback. If they do not, then what can happen, for example, you have negative RFR because the disease is very focal, and then you have a positive FFR because of a very focal disease. If you do a pullback with RFR, you will see this jump. It's just not going to be as pronounced because you're starting with a negative RFR. And I would most likely stent the lesion if the patient is symptomatic, because this is a focal lesion, and the discrepancy between the FFR and RFR is because the lesion is very focal, which is usually picked up by hyperemia and not in the resting conditions. So I think these are kinds of discussions outside of the scope of literature which we need to have to better treat the patients. Panos.
I would just like to pick Simone's brain on the FAVOR 3 trial again. Do you think that this is a class effect for all angio-based physiology systems, or is it only a result that pertains to this particular technology and index?
I mean, I think that because we gave a lot of thought of thinking about the FAVOR 3 trial. If you have a look, for example, at the results, you will see that, for example, the most the country that included more patients was Italy, because we were inside the study and coordinating Italy, and we asked for the results of the Italian patient because we wanted to know whether it was actually an arm also in our setting. And in our country, the rate of events was 5.5, 5.5. So it was completely the same. There were two big outliers in the study. There were two countries, one with 17% of events in the QFR arm and one with 0% of event in the FFR arm. So I don't know if it's a class effect of the systems. It could be a class effect in terms of operator interaction, because this is true for all the systems right now. So all the angio-derived FFR systems have some operator interaction. Some of them have more, some of them have less. But this is something that we have to solve in order to be able to use it on a daily basis. At the same time, if you have a look at the study that was done by Serraius and the Galway group, they perform a blinded evaluation with all the systems with the same in the same patient and the same lesions, and they end up with the similar area under the curve if compared to FFR among all the systems, but it was lower if compared to the one of the studies done by the companies. So the area under the curve was around 0.70. So it has a moderate correlation with FFR right now. That's what we can say.
So it's actually interesting what you highlighted. So you would say that the angio-based systems at the moment are more user-dependent than the wire-based.
Oh, 100%. You cannot change the FFR. Instead, I mean, you can put the wire down the vessel, but then you cannot change the value you see from the FFR. If it's 0.85, it's 0.85. What you can do because you have the automatic tracing of the vessel, but most of the times you have still to check and to correct some points. And obviously this can hugely modify the analysis, because if you have, you see a 90% stenosis in the proximal circ, and then you say, oh, come on, the patient is symptomatic. There is 90% stenosis in the circ, and the QFR is 0.81. Probably it's not good, the contour tracing at the level of the stenosis. So what you end up doing, even if you are not doing on purpose, but is to check, to correct, to change, and then obviously to alter the analysis. So you will end up, but that was actually factual in the study, because you have many circumflex artery positive and right positive in the QFR arm if compared to FFR. That can be a limit of the technology per se, because obviously...
At the moment, until it's fully automatic, as you said. So AI will help in this patient.
Yeah, we will have other studies, because the FAST-3 trial from the PI Medical will be presented at TCT, and it's very similar to the FAVOR-3 Europe and Japan in terms of study. So we will know in October if it's the same or something is different.
Great.
So we will know a little bit more.
Thank you, Professor Gioliumi.
No, I wanted to reinforce a little bit this aspect that Simone was mentioning, because many times also in the LAD you have small branches that we are not detecting. You move frame by frame and you can see the difference in the contour trace by the machine. You might have a dishomogeneity of the contrast and you can see the difference. And also the quality of angio is dramatically important. Yeah. So all these are variables that might impact significantly the result.
Thank you very much. Thank you, Simone. This was very, very insightful. I think very clear messages. So